Welcome to the Explainer. Today we're diving into cowpox virus. It's a pathogen with this legendary backstory in medicine, but it's posing a very modern challenge. See, we're living in a world that's largely unprotected against orthopoxviruses for the first time in centuries, and this old zoonosis, well, it's starting to find new opportunities.
Right. Before we jump in, just our usual heads up. All of this analysis was put together using a Gemini deep search. If you want to dig into the primary literature yourself, you can find a complete list of all our sources in the linked Notebook LM document. To really get why we're even talking about cowpox virus today, you have to look back at one of public health's all-time greatest hits, wiping out smallpox. For generations, that vaccinia virus vaccine acted like a shield, giving us this broad, cross-protective immunity against a whole family of related viruses, and that included cowpox virus. But then we stopped routine smallpox vaccination back in the late 70s, and ever since we've been building this massive, immunologically naive population. So the thing is, this isn't about the virus changing, it's about us. We've created a susceptible landscape that this virus hasn't seen in 200 years. And well, other zoonotic orthopoxviruses are definitely starting to take advantage of that gap. Okay, so here's the plan. We're going to start with why this is a re-emerging threat. Then we'll get into the virus itself and its cycle, how to spot a case, the lab strategy for diagnosis, how we manage it clinically, and we'll wrap up with a close look at the public health response right here in the Netherlands. Let's do it. So let's talk about the re-emerging threat. Honestly, the 2022 global Mpox outbreak was a massive wake-up call. It was our first big test in this new reality, and it showed us just how fast a zoonotic orthopoxvirus can race across the globe, completely shattering all those old ideas we had about geographic containment. In a lot of ways, Mpox was basically a dress rehearsal, a really critical one. All the hurdles we had to jump with diagnostics, with tracing, with getting antivirals out the door, that whole experience gives us a direct blueprint for what we're up against. It shows us what we're good at and where the gaps might be when another one like cowpox virus shows up. All right, section 2, the virus and its cycle. So, what is this virus exactly? And more importantly, how does it actually get to humans today? Let's break down where it fits in the family tree and how it moves around in the modern world. Okay, now this table is super interesting because it puts cowpox virus in context. You can see it's in the same club as smallpox and Mpox. In fact, look at that genome. It's the biggest of the bunch. But, and this is the crucial part, look at that row for human-to-human transmission, not reported. Unlike its infamous cousins, we are basically a dead-end host, and that is a huge deal epidemiologically. And we have got to get this next point straight because it's a big one. The name cowpox is, well, it's a total misnomer. Yeah, Jenner's work involved cows, but they are not the natural reservoir. The virus actually lives in wild rodent populations. We're talking voles and wood mice all across Eurasia. Modern human cases are almost never, ever traced back to cattle. So how does it get to us? Well, the path almost always involves a middleman, a spillover animal. The virus jumps from its rodent reservoir into an animal we have much closer contact with. And the number one culprit? The domestic cat, who picks it up while hunting. We're also seeing more and more cases tied to pet rats. Then we get infected when the virus gets into our skin, usually from a scratch or a bite from that infected pet. Okay, on to the clinical side of things. Recognizing a cowpox virus infection can be really tricky. And as you're about to see, getting the diagnosis wrong can lead to a really bad therapeutic choice. The lesion itself, it takes its sweet time. In a healthy person, the progression is incredibly slow and often quite painful. It starts as just a red spot, but over weeks, it moves through all these stages, vesicle, pustule, and then you get the hallmark sign. Between weeks 3 and 6, this deep, hard, black eschar. It can look pretty dramatic. The whole thing, from start to finish, can take 12 weeks. That's 3 months to heal. Now, put yourself in the clinic. A patient comes in with a single, painful, swollen lesion. Your first thought probably isn't going to be a rare zoonotic virus, right? It looks a lot more like a really bad reaction to an insect bite or maybe some other kind of skin infection. So what's the go-to treatment for a gnarly inflammatory skin reaction? You guessed it, a topical corticosteroid to calm things down. It's a logical first step. But in this case, that instinct is a catastrophic mistake.
And here is the single most critical clinical takeaway of this entire talk. You do not put steroids on a cowpox virus lesion. It's completely contraindicated. What happens is the steroid shuts down the local immune response that's trying to fight the virus, and you can end up with this severe, progressive necrotic ulcer. It turns what should be a self-limiting infection into a disaster.
So, this is where we in the lab become absolutely critical. Getting a definitive diagnosis means using a combination of tools, and each one has its own strengths, its own speed, and, its own weaknesses. When you look at the options here, you see that classic trade-off, right? Speed versus specificity. But look at PCR. The huge challenge with our go-to method is that cowpox virus is incredibly diverse genetically. It's not one single thing, it's a whole collection of different clades. So an assay that you developed for one strain might totally miss another one, leading to a false negative. This means we have to constantly validate our assays, and it really makes the case for using sequencing for the final confirmation.
Okay, so what do we do once we have a diagnosis? Well, for most healthy people, the infection will clear up on its own with just supportive care. But for severe cases or for our high-risk patients, we do have some antiviral cards to play.
The big thing to remember here is that we don't treat everybody. This is reserved for those really specific high-risk situations. The first-line drug is Tecovirimat, and what's great is that it's actually registered by the EMA specifically for cowpox virus, which makes it much easier to use here in the Netherlands. This is right in line with what international bodies like the CDC recommend. Of course, for kids, it's also considered in severe cases. You just adjust the dose by weight. And while resistance isn't a big problem yet, it's definitely something to keep on the radar.
So, that brings us to public health. How does the Netherlands handle a case of cowpox virus? Well, the entire approach is fundamentally zoonotic. It's all built on this principle of One Health. What this One Health framework means in practice is that a human case isn't seen as the start of an outbreak. Instead, it's treated as a sentinel event. It's a bright, flashing signal that the virus is active in the local animal population. So the GGD doesn't start looking for human contacts. Instead, they trigger a traceback investigation with the vets. The goal is to find the animal source and stop it from infecting anyone else.
And this slide just perfectly captures the hybrid response. It's fascinating. The public health investigation is purely zoonotic. Go find the sick cat or the pet rat. But inside the hospital, the infection control is super strict, just like it would be for a virus we know spreads between people, like Mpox. The patient goes into a single room, full contact, and droplet precautions. It creates this really robust firewall in the hospital, while the public health teams focus their energy where it really matters, that human-animal connection.
And that really brings us to the final big question. Mpox showed us that viruses we've known about for decades can suddenly and dramatically go global. So as our collective immunity from the smallpox days continues to fade, you have to ask, which of these old pathogens is going to be the next one to step up and challenge us? To stay on top of deep dives like this one, please make sure you subscribe to the channel. We'd love to hear your own professional insights and questions, so please share them in the comments below. Thanks so much for watching.